I'm going to talk about the natural history of hepatitis C and a little bit about the epidemiology and the need for treatments, both from an individual but also from a community point of view. New therapies and the emergence of interferon-free regimens for hepatitis C treatment, which are a huge step forward for many of our patients. We need to think about which patients should be treated right away and which should wait. And then a little bit more specifics about side effects and their management, particularly with the new agents of Telaprevir and Ribavirin on board. So looking at the natural history of Hep C, following exposure, as we've heard, approximately 70 to 80% will become chronic. Out of those, about 40% will develop cirrhosis. And there are many contributing factors into the progression of hepatitis C, as we all know. So if you're co-infected with HIV or Hep B, if you're obese, if you drink alcohol, then all of these things will contribute to the progression of disease. So as we know, most of our patients with hepatitis C also drink alcohol, and they also have a history of polysubstance abuse, etc. So we're not dealing with one specific disease. We have to deal with the patient as a whole and all of their other problems. So looking at the natural history of hepatitis C, about 50% of patients after about 25 years or to 30 years will end up with cirrhosis, and a lot of those will go on to develop hepatocellular carcinoma or liver failure. So if we have a patient in their 50s who's usually been injecting drugs in their teenage years or in their early 20s, then a large proportion of them we know will be cirrhotic. So in Australia, there's about 250,000 people that are infected with hepatitis C at present, and we know that out of those, currently about 6,500 or 3 or 4% are living with cirrhosis. It was estimated in 2009 that about 300 of these went on to develop liver failure and about 150 developed hepatocellular carcinoma related to hepatitis C. And it's fair to say that only a very small percentage of these patients could be salvaged through liver transplantation. This is from Greg Dawes' epidemiology data in hepatitis C, and we can see that by 2015, there's going to be about 3,000 to 4,000 hepatitis C-related deaths in Australia. So it is a huge community problem, meaning that we really need to get on and tackle it. So we need to make the treatment easier, and one of the important things has been the removal of liver biopsy. And if we look back at when liver biopsy was removed in 2006, we look at this large spike in the number of patients treated per year, which almost hit 3,000 back in 2007. And it's about 1,000 patients per year increase just from the removal of mandatory liver biopsy prior to treatment. So I think we need to look at strategies which are going to make hepatitis C treatment a lot easier. In order to have an impact on the epidemic, we need to increase the treatment numbers, which is currently around 2,000 to 3,000 per year, up to about 10,000. So we still need more people to treat hepatitis C. We still need the nurses. We really need to increase the number of patients, not only that are being treated, but also that are being diagnosed with hepatitis C. So in Western Australia, looking at our local data, only about 1% of the 15,000 patients living with hepatitis C currently have access to treatment. And an optimal model needs to be developed in which we can actually address the problem. So we need to, in the United States, there's been a lot more promotion for hepatitis C treatment. And this came out when Telaprevir and Ribavirin were released. And at the same time, the Centre for Disease Control found that we should really screen all patients born between 1950 and 1964, so all the baby boomer generation should be screened for hepatitis C when they come into contact with their general practitioner, because of the very high prevalence of hepatitis C within that population. So we need to prevent hepatitis C. We need to establish a good model of care. We need to improve access to treatment, and we need to manage the complications of liver disease and also screen for hepatocellular carcinoma in order to prevent its devastating consequences. So in 2012, here in Australia, we got the new antiviral therapies, both Ribavirin and Telaprevir, for genotype 1A. Unfortunately, patients with genotype 3 are still left without any improved treatment from the older interferon-based therapies. And with these new treatments, we're seeing increased SVR rates, which are about 20 to 30% higher with triple therapy versus peg interferon and ribavirin alone. So we know that patients that undergo Boceprevir as well as Telaprevir therapy are going to get about a 70% SVR now for genotype 1. The other nice thing about these therapies is that we can shorten therapy for patients that respond very quickly. However, all of these therapies are still interferon-based, and therefore these patients still need close monitoring and pre-treatment counselling, and so there is still a very strong role for nurse coordinators. So we've seen the new DAAs, Telaprevir and Boceprevir, which is still interferon-based, but the future looks pretty good because interferon-free therapies are coming. And we know that GS7977 or Sofosbuvir, Cimeprevir, or the new Abbott drugs, as well as about another 6 or 7 drugs, are in the pipeline. So we know that combinations of these therapies, hopefully without interferon, probably still with ribavirin, are going to be available probably in the next 3 to 4 years. So the question is, should we treat now or should we wait? So let's look at a case. This is Miss EW. She's a 54-year-old female, genotype 1 hepatitis with remote history of intravenous drug use during her teenage years. So again, this is somebody who's probably had about 25 to 30 years of exposure, if not more. She's a drinker. She was drinking a couple of wines per day. She was keen to undergo antiviral therapy, and she works full-time as an English teacher. Her current weight was 54 kilograms, and on examination, she had some spider angiomas on the face and chest, and she had a palpable liver. And these were her bloods. She was genotype 1. She had a highish viral load and normal platelet count, ALT of 94, and a HEPA score at 0.84, and a slightly elevated alpha-fetoprotein. Her IL-28 beta was CT. Her initial ultrasound just showed coarsened liver echo texture with a normal spleen, and which she went on to have a triphasic CT given the raised alpha-fetoprotein. She had mild hepatomegaly with a smooth surface but coarsened liver echo texture, but no cancer seen. So most of us would agree that we would treat this lady now. And looking at in the past with the old treatment, just with peg interferon and ribavirin, with the CT genotype, plus advanced fibrosis, F3 to F4 fibrosis, this lady would probably only have about a 20% chance of cure. However, with the new treatment, we could now say that with CT genotype, should be looking at about a 70% cure or SVR. So I think we're much better at counselling patients and giving them prognosis. Let's contrast this chap. He's a 26-year-old male with genotype 1 hepatitis C, remote history of intravenous drug use during his late teens, and works as a fly-in, fly-out worker to Karratha as a fitter and turner. He's married with 2 children, has a mortgage. He's very concerned about his ability to work throughout treatment, and his HEPA score is only 0.25, and his IL-28 genotype is CT. So I think it'd be reasonable to say that because of this chap's circumstances, it's reasonable to wait a couple of years until an interferon-free therapy would come out. So having said that, even currently there are some what we'd call near absolute contraindications to interferon for hepatitis C. And I think we'd all agree that patients with severe uncontrolled autoimmune disease, such as rheumatoid arthritis or SLE, it'd be difficult for them to tolerate interferon because of exacerbation of their disease. Patients with severe unstable psychiatric disease with a recent suicide attempt, I think most of us would be a bit reluctant to give this person interferon. Well-controlled psychiatric disease, I think we're all relatively comfortable with, and we have good psychiatric liaison support. A history of prior interferon intolerance and early cessation always rings alarm bells for me, and I think, why would we expose this person to interferon again unless something had really radically changed in their life? A history of ongoing drug abuse with a disorganized lifestyle. I've had a few patients turn up to clinic requesting therapy, and you look at their notes and they have an ED admission with a recent drug overdose, with a heroin overdose, or etc. So I think that sort of patient none of us would really like to treat. Obvious poor compliance and ongoing alcohol abuse are other things that would make us a bit more reluctant to treat. So going back to our first lady, the 54-year-old with advanced hepatic fibrosis, she commenced treatment with peginterferon, ribavirin and boceprevir last July. And she had the 4-week lead-in phase with peginterferon and ribavirin and got about a 1 log drop in the first month. However, she was feeling extremely tired, was weak, was unable to work, had to take a lot of sick leave. She started to lose weight and she had quite a significant hemoglobin drop. We then added in boceprevir after week 4, and at week 6 her hemoglobin dropped further to 89. We then dose reduced her ribavirin down to 600 milligrams, and by week 8 her hemoglobin had improved a little bit. The encouraging thing was that her hepatitis C RNA then became undetectable. At week 11 she was seen again, and her hemoglobin at this stage was 79, so we managed to get erythropoietin for this lady, which we can justify at Royal Perth by just using it in very high-risk patients who we think have at very high risk for anemia as well as have cirrhosis and would really benefit from therapy. However, by a week later, her hemoglobin continued to drop. We probably added in the erythropoietin a little bit too late, and she required a 2-unit transfusion. So this just goes to show that, that patients like this do still have significant side effects. We know from recent data that anemia management in hepatitis C, dose reduction is just as good as erythropoietin from this study by Pordad. So if we can get away with dose reduction and the patient's asymptomatic, then it's probably the way to go. So hopefully we could not use very many growth factors in these patients. So looking at more detail in the side effects of interferon, all of us who work in the hepatitis C clinic would be very familiar with these side effects and how to counsel patients. But the most common things are the flu-like symptoms, headache, fatigue, myalgia, fever and chills. And we usually advise people to use paracetamol, rest, fluids, using the timing of the injection to fit in with their work schedule. So people that work Monday to Friday usually have their injection on a Friday afternoon so that they can take the weekend to recover and it cannot interfere with their work schedule. There's gastrointestinal side effects, nausea, diarrhea. Weight loss is often a problem. You can usually manage that with antiemetics, PPIs, as well as Imodium. Thyroiditis, we usually need to monitor the TFTs very closely. Alopecia is also a common problem and can be a particular concern for women, but it is usually reversible following cessation of treatment. Psychiatric side effects remain a significant problem, and this does consume a lot of resources, both from ourselves as well as our nurses, as well as our psych liaison. That does respond very well to counselling as well as SSRIs, and sometimes dose reduction of the interferon can also help. Injection site reactions need to often be managed, such as by usually rotating the injection sites and suggesting good skin care. I tell people that one of the difficult things is they require close monitoring, and of course for people that are working full-time it means getting to the lab to have bloods done and things, and that can often be challenging, particularly for in this current age of the fly-in, fly-out worker. But we do see lots of risks of anemia, neutropenia and low platelet count as well. And so we have to watch them very carefully and dose reduce ribavirin, interferon, and occasionally there may be a role for growth factors and GCSF, although as we've seen we don't really improve SVR, but we may improve symptoms and make ourselves feel a little bit better. So with ribavirin, the specific major concern is hemolytic anemia, which we're all very familiar with, and this is often exacerbated by the new direct-acting antiviral agents. Pregnancy counselling is extremely important, and fertility counselling, and it's often a reason for delaying therapy for female of childbearing age if they're planning on having children in the near future. The respiratory side effects can be difficult to manage, and I've seen a couple of patients who, because of severe cough and wheezing, have had to actually stop treatment related to ribavirin. And that's not a very common side effect, but it is well documented. And rash, which can be quite difficult to distinguish from the Telaprevir-associated rash, which can be challenging. So looking more specifically at the new agents, boceprevir and Telaprevir, we're seeing higher rates of anemia with boceprevir, as well as dysgeusia, which is a weird taste in the mouth or a dry mouth, a metallic taste that people complain of, and Telaprevir rash, which I'll talk about some more. this was one of the most concerning new side effects with hepatitis C therapy. But however, one of the relieving things was that severe rash is actually not that common. It was found in less than about 4 or 5% of patients. And this is what it looks like. So initially you can get very mild, localized sort of maculopapular rashes, which can then become more severe. And if you've got more than 50% of your body surface area involvement, that is classified as quite severe, and that should definitely involve stopping the Telaprevir. But it can be very difficult because both interferon and ribavirin can also cause similar rashes. The other unusual, weird side effect was when they first started using Telaprevir is that people started complaining of peri-anal pain and pruritis, and couldn't really work out what it was, but obviously it is the Telaprevir, and a lot of people will complain of pruritis ani while they're on this drug. So with regard to rash, when assessing rash in these patients, look at the body surface area, and an easier way of doing it is to look at the rule of nines, where each of the upper limbs is about 9% of body surface area, the legs about 18%, and the back and front, each of the chest or the abdomen are each about 18%. So using that estimate, you can work out on the severity of the rash. You can often give your dermatologist a little bit of insight about what you're worried about. And we've had to stop treatment so far in 2 patients on Telaprevir with rash out of about 20 patients or so that we've treated with Telaprevir. The other concern is in cirrhotic patients with these new drugs, because from the CUPIC study in France, the early access program, there have been a number of cases of decompensation and death. They also saw much higher serious adverse events compared to the initial phase 3 studies. So about 1/3 of patients, up to about 50% in some series, versus only about 10 to 15% in the phase 3 studies. And of course, these were sicker patients who were not as carefully selected. They also saw high rates of discontinuation and of course deaths. And most of the deaths occurred because of sepsis and liver decompensation. The important things to take out of this study, and I guess we're a little bit lucky in that we got the drugs a few months later, is that we can look for patients with low albumin or low platelets or obvious portal hypertension that are likely to decompensate in relation to these therapies. The other concern is drug interactions. We know that Telaprevir and boceprevir both interact with many other drugs, so you have to be very careful with drugs such as midazolam or digoxin. Post-transplant, you have to be extremely careful, and I'm not sure if anyone here has been treated yet in the post-transplant setting because of the concerns over the interactions with cyclosporin and tacrolimus. Antidepressants, particularly the SSRIs, escitalopram, can be affected and should be used with caution. And there's a good website to refer to drug interactions where you can get a lot closer, a lot more information and updated information. So that just about wraps up what I have to say, but just to summarise, the new therapies, there's no doubt that they do improve response rate. However, the side effects still remain a major issue given that the therapy is still interferon-based. And if we're going to be treating cirrhotic patients with a view to preventing the need for transplant and saving patients from other complications, we're going to see a lot more serious adverse events, the risk of death. There's going to definitely be a need for ongoing close monitoring and counselling of these patients. So there's no doubt that some patients with very early stage disease who are young, have a short duration of therapy, who don't have any signs of advanced fibrosis would benefit from waiting from the new therapies. Thanks.